Hi, I'm Efrat. Today we will talk about Tourette syndrome. Submit assignment is Einat, Efrat, Tamar, and Livnat. Introduction to Tourette syndrome, definition and classification. Tourette syndrome is defined as a neurodevelopmental disorder belonging to the group of genetic and biological disorders and affecting the function of brain and central nervous system. This disorder characterized in four symptoms. The first one is the appearance of tics. The appearance of motor tics, multiple motor tics, that the tics are involuntary movements, and one or more vocal tics, such as sounds or words. The tics appears to appear and disappear in waves, but not necessarily simultaneously, but and are characterized by a waxing waning pattern in both intensity and frequency with a mix of old and new tics. We will define now the tics by the DSM-5 in 2022. A tic is a sudden, rapid, repetitive, and non-rhythmic motor movement or sound. It has having a fixed or rhythmic rhythm, and the repeating in the same time pattern regularly. A person may be free of tics for a period of time, but even if there are periods without tics, they can return at any time. Although tics are generally considered involuntary, they may be voluntarily controlled for varying length of time, and this varies from person to person. We will talk about more. There are two kinds of tics, motor tics and vocal tics. There are simple motor tics and complex motor tics, and simple vocal tics and complex vocal tics. The simple motor tics are sharp and short, and they repetitive. They appear involuntary. They involve a single muscles of a group or a limb, single muscle group limb. Primarily eyes and mouth. Later on, we will see neck and limbs. For example, blinking eyes, rolling eye, eye rolling, eye or mouth opening wide, neck tilt, shoulder shrugging, hand shaking. Like this. It's not like this, which characterize more the autism, but it moves without notice. The motor tics, the complex motor tics, involve several muscles groups and appears as this decreased or coordinated movements. Meaning the simple motor works for one single muscle or one group of single muscles. The complex one is involve couple of several of um, groups. Examples: touching or patting, flapping, kicking, jumping, acroprexia, which means imitation of gestures, and choreprexia, which means obscene gestures or inappropriate touching. When I talk about the vocal tics, the simple vocal tics uh, are meaningless voices or sounds produced by the flow of air through the nose or through the mouth or through the throat due to con- due to contraction of the vocal cords or um, respiratory muscles, pharynx, mouth, and nose. For example, uh, cawing, clearing, growling, imitation of animal sound through throat clicking like this. The complex vocal tics involve multiple muscle groups and are expressed in words or phrases or sentences. Um, for example, shouting or screaming, echolalia, which means repeating what others said, corporalia, which means inappropriate social expressions. Corporalia occurs in about 8% till 17% of people with Tourette syndrome, most often around the age of 15. I have to tell you that I know someone with the tics, and it's not nice. Um, Especially when we are talking about the vocal, the, the motor tics. You look at the man and you think, oh, the man is weird. But when you hear him, the vocal tics, sometimes he talks not that nice. He curses or he shouts, and it's I think it makes him very to feel he knows that something is wrong with him. He knows that he has Tourette, but socially it's a problem. It's a very big problem. We'll talk about later. It's not nice. The second of the character is the duration of tics. The tics last for over 1 year since the first tics appeared. The age of one set of tics, one set of disorder before age of 18. The fourth one is absence of known cause, such as another medical condition or substance use. We have to we have to make sure that the tics are belong to the Tourette syndrome. We don't want them to be belong to uh, various um, of another diseases like Huntington disease or medications that the man takes, maybe drugs or another medical conditions. So we have to make sure that it cannot be attributed to the use of these kinds of diseases. Development and course. Tourette syndrome affects the brain and central nervous system, and it usually starts at age 4 to 6. The syndrome reach the peak severity as at 12 till 14 years of age, after which there is a trend towards a decrease in severity of symptoms during adultnesses, especially in the reduction of the intensity of the tics. In some cases, symptoms may persist into adulthood, although they often disappear or decrease. The tics may change location on the body and vocal nature over time. I have to tell you, the man I know is a grandfather today, and still has this syndrome, and it decreases. He takes pills and um, medications that the doctor gave him, but um, he has the motor, he has the vocal. It's better because he's under medications, but he had to um, cooperate or to deal with this all his life. It's not easy. It caused him unpleasant situations. During adultness and adulthood, many people with Tourette report a feeling of discomfort before the tics occurs, called a premonitory urge, and they sometimes experience temporary sense of relief and reduced tension after performing them. Therefore, although the tics are experienced as involuntary, some people can, to some extent, suppress them for a limit time, which means that we talked about before, but some people can hold, can limit the tics, the appearance of tics, but they can do it for a limit time. Afterwards, it comes out again, and he pays for it. We'll talk about later. Functional implications. Tourette syndrome can affect many areas of life: personal, social, academic, and occupational functioning, as well as emotion, learning, self-rejection, regulations, and control, and momentary and memory processes. Uh, all this they pay because they have this syndrome or the tics. Even if they can limit the tics, it's for, as I said, for a limit time, and it takes from them a lot of cognitive resources. They have to invest lots of resources, concentration, emotional distress. They it's very they have sometimes some of them have suicidal thoughts. Um, they pay because of the tics and the syndrome. They pay socially, academically, because they can't concentrate um, to the what they have to do. It just come out. Um, um, it's not easy. They don't have an easy life. History and discovery of Tourette syndrome. The history of the Tourette it started in 1825 when was the physician Jean-Marc Jasper Lettard. He first described the case of a French noblewoman who suffered from involuntary body movements, including movements of the shoulders, neck, and face, along with vocal tics such as barking and foul language. This description is considered one of the first documented um, reports in the history of tics disorders. Early in the history of disorder, these tics were viewed as uncontrollable behaviors or as strange behaviors that occurs for no apparent reason. In 1885, the French neurologist Georges de la Tourette, he also suffered from this disorder. He reported 9 additional patients with tics disorders. In fact, the first official diagnosis of Tourette syndrome is attributed to the French neurologist Georges Gilles de la Tourette, and those laying the foundations of recognizing this syndrome as a neurodevelopmental disorder. Follow this, clinical studies began to be conducted in the field of diagnosis and treatment of the syndrome, and in the recognition that Tourette syndrome is neurobiological disease. Till here, thank you.
Etiology, cause and possible cause of Tourette syndrome, biological factors, disruption of dopamine activity in the brain. Dopamine is an important substance in the brain that is involved in controlling movement. In people with Tourette syndrome, there is a probably excess dopamine activity, where the brain is overly sensitive to dopamine. This occurs especially in areas such as the basal ganglia, deep area of the brain responsible for coordinating movement. The frontal lobe, prefrontal, which is associated with self-control. The fact that dopamine antagonists such as Helidol or Risperdal relieve tics strengthen this hypothesis. Change in brain metabolism. Studies have shown that there is a different use of glucose in the brain of people with Tourette. Parts of the brain are more active than usual, such as the premotor cortex and cerebellum. Others are less active at rest, such as the striatum and orbicularis occipitalis. This suggests that the brain of people with Tourette is also behave differently in terms of energy. Damage to the GABA systems inhibits movement. GABA is a substance whose functions is to inhibit unnecessary movement or impulses. In Tourette's, there may be an abnormal distribution of GABA receptors, which cause a decrease in the ability to inhibit movement and the appearance of tics. This particularly affects areas such as the thalamus brain control center, the amygdala emotion, the insula body sensation. Genetic factors. Students indicate that Tourette syndrome has a distinct genetic basis. The disorder has been found to be more common in first-degree relatives of children with Tourette syndrome, suggesting a significant hereditary component. Extensive genetic studies conducted over the past decades have reported the finding showing that Tourette syndrome has a polygenetic structure that is the cumulative effect of many genetics variants, each of which contributes in a small but cumulative way to the risks of developing the disorder. Genetics variants contribute significantly to the heritability of the disorder. This is estimated that approximately 58% of the heritability to Tourette syndrome is explained by common genetic variants alone. In addition, rare genetic variants also exist. Polygenetic risk scores were found to correlate with tics severity, suggesting a link between genetic and the behavioral expression of the disorder. Environmental factors. Environmental factors during pregnancy and childbirth. Intrauterine and parental injuries, environmental complications during childbirth, such as hypoxia, decreased oxygen supply, and anemia, decreased blood supply, to the brain near birth, premature birth, breech presentation, cesarean, sensation, low birth weight, natural smoking during pregnancy, advanced sense age of the father may affect the development of the fetus nervous system and disrupt brain pathway relates to movement control. Childhood head injury. Events such as meningitis or head injury are not considered direct cause, but can be contributing factor or worsen the condition in susceptible children. Impact of autoimmune infection of children, Pandan's syndrome. There is a theory that a strep infection can cause the immune system to mistakenly attack the brain. This happens in some children and can cause a sudden onset of tics and compulsive behavior. This phenomenon is called PANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcus. Pediatric autoimmune neuropsychiatric disorder associated with streptococcus infection. Environmental factor worsen or improve tics. Tics improve with calm, focus activities, for example, writing, reading, playing music. Tics are made worse by anxiety, fatigue, excitement, stressful events such as a test or significant social events. Prevalence and demographics. Tics are common in childhood, but in most cases there are straightening. According to DSM and other studies, they estimate prevalence of Tourette syndrome in school-age children range from 3 to 8 cases per 1,000. Some studies indicate a prevalence of about 1% in large population survey, with some national surveys in the United States report about 3 cases per 1,000 children. boy compares to girl. In most studies, the syndrome appears to be more common in boys than girls, with a ratio varying from 2:1 to 4:1 in favor of boys. Women with chronic tic disorder are more likely to suffer from anxiety and depression. Culture influence. Tourette syndrome has been identified worldwide, regardless of ethnic origin, but there may be dispar, dispar, disparities in recognition between population due to culture or social factors. Some ethnic groups tend to under underrecept underreports case of the syndrome, which may be related to difficulty in recognizing the disease. Lack of awareness on the part of individual or family, or failure to seek a personal help and to seek professional help. Culture and society may influence how people interpret the appearance of tics, their awareness of their existence, and pattern to seeking treatment. Therefore, the data obtained may not always reflect the true rates of the syndrome in different communities. Ah,
Physical characteristics. There is no special external appearance for a person suffering from Tourette syndrome. The external characteristics are expressed in the physical form and nature of the motor and vocal tics. Cognitive characteristics. Tourette syndrome is not considered a cognitive disorder, and in most cases, people with Tourette's have normal intelligence, but it is accompanied by cognitive characteristics, psychiatric symptoms, and sometimes disorders, partial sense of control. Most people with Tourette's can suffer tics for a short time, indicating some cognitive control is involved, difficulty with executive functions, planning, organizing, emotional regulation, and impulse control, ADHD, and attention deficit hyperactivity disorder, the most common disorder alongside Tourette's. Attention deficit hyperactivity disorder with or without hyperactivity, characterized by distractibility, impulsivity, and hyperactivity. ADHD is diagnosed in about 50% to 60% of cases. Possible comorbidity alongside Tourette syndrome. Obsessive compulsive disorder, OCD, or compulsive symptoms, characterized by intrusive thoughts, obsession, repetitive rituals, compulsions, and the sense of not being right that needs to be corrected. Very common, 30% to 60% of children with Tourette's also have OCD or OCD-like symptoms. Behavioral disorders, ODD, and conduct disorder, especially associated with children with ADHD, characterized by resistance to instructions, defiant or aggressive behavior. Disorders of emotional regulation, difficulty regulating anger, strong or extreme emotional reactions. Anxiety disorders, especially common in children and teens with Tourette's, including generalized anxiety, social anxiety, fear of being ridiculed because of tics, phobias, depression. It is mainly observed in adolescents and adults with Tourette's, especially when there is social distress, a sense of shame or rejection, and there is ongoing functional difficulty. Behavioral characteristics, non-complaints, tantrum. Among children on the autism spectrum, 6.2% suffer from Tourette's, a rate 10 times higher than the general population. Implication for behavior analysts in the treatment of Tourette syndrome. Behavior analysts face many challenges when working with patients diagnosed with Tourette syndrome. Here are some of the main challenges. Distinguishing between voluntary and involuntary behaviors. One of the main difficulties for behavior analysts is differentiating between involuntary tics and learned or intentional behaviors. Tics are usually automatic and not the result of behavioral reinforcement. However, in some cases, tics can be influenced by environmental factors, which can complicate behavioral analysts' work too. Presence of comorbidities and prioritizing treatment. Most individuals with Tourette syndrome also suffer from accompanying psychiatric disorders such as ADHD, OCD, anxiety, depression, sleep disturbance, and self-injurious behavior. These comorbidities affect the success of behavioral treatment and require personalized adaptation of intervention programs. Moreover, it is important to differentiate between behavior originating from tics and behaviors stemming from other disorders to ensure appropriate treatment planning. The most effective intervention strategies for treating tics in Tourette syndrome are behavioral therapies, primarily CBIT. In their article, Einat and colleagues addressed the reduction of dangerous behavior related to Tourette syndrome using the habit reversal training, HRT, method and demonstrated an intervention approach that can be implemented despite the challenges and difficulties. The habit reversal training method is conducted in 3 stages. 1. Awareness training, which include response description. Awareness of the habit is increased by having the patient describe the behavior in details. Response detection. The patient learns to recognize the behavior as it occurs. Early detection. The patient learns to identify warning signs or early stage leading to the behavior before it is fully executed. 2. Competing response training. A competing response is a behavior that the patient learns to perform, which prevents or makes it difficult to carry out the tick itself. As soon as the patient notices the warning sign that a tick is about to occur or realizes that the tick has already started, they are immediately asked to begin performing the competing response. 3. Social support. At this stage, family members or friends are thought to praise the patient wherever they use the competing response. When working with individuals diagnosed with Tourette syndrome, behavior analysts must consider essential ethical principles. Foremost among them, the principle of respect for the patient's well-being. It is important to assess whether the tics themselves cause functional or emotional difficulties for the individual or whether it is the environment that struggles to accommodate them. According to Blake and Uda, intervention decisions should be made only when tics impair functioning, quality of life, or self-image, not based on external social pressure.
Hi, I want to share that I have a friend, her name is Emily. She has 3 boys the same age. Next month they celebrate their 18th birthday. Before 12 years, her son Liad was in first grade at age 6.5. He suffered from visual tics, blinking with the eyes. And his teacher was an amazing woman. She explained all the kids that stress and tension can lead to many things. One child will speak a little and whisper. And Liad, when he stress, when he has a stress, he blink a lot. And thanks to the teacher, the children ignore the tics. And she allowed Liad, when he feels stress, to go out and wash his face. And after 3 months, the tics stopped completely. Okay. Now I present the hypothetical clinic example. Noam, 11 years old. General background. Noam was diagnosed with Tourette syndrome at the age of 8. Tics first appear at the age of 6, including the eye blinking, neck movement, and throat sounds like this. At age 10 until 11, more prominent vocal tics emerge, such as sudden vocalization, along with repetitive hand movement. Noam also had ADHD with impulsivity and difficulties in emotional regulation. Noam reports that in recent months, classmates have been laughing and writing into his tics, some mockingly and some by imitating him, imitate the tics. Noam sometimes respond with outbursts of anger, including shouting, slamming the door, and running out of classroom. He is able to suppress tics from a short period, but experience strong physical discomfort when doing so. He has a difficulty falling asleep, and his sleep is not well. He wake all the time. The intervention goals are reduce the frequency of anger outbursts, improve social function, support coping with tics in supportive environment, and strengthen emotional regulation and adaptive response to social pressure. Before we do the intervention plan, we did the function assessment, identification of situation that lead to anger outbursts, like laughter from the kids, environmental response, and reinforcing condition through observation and functional assessment. For example, kids mock or imitate Noam sticks. Noam shut, eat them, slamming the door, and leave the classroom. The teacher silenced the kids, and Noam escapes the social situation. The function identified the escape from an aversive situation. The behavior is reinforced by a social negative reinforcement, meaning Noam escapes an unpleasant, aversive, like I said, situation through his outbursts, which leads to the termination of the aversive experience. Okay, the behavioral intervention plan for Noam. Teacher meditation. The teacher will explain Tourette syndrome to all the class without embarrassing Noam, of course. Encourage experience, promote emotional discussion about the tics, and guide the children on the expected behavior when they notice Noam's tics. Noam will be taught to express his distress in a detective way by using a sentence such as I need a moment, can I step out for a moment? Also, parent and staff training. Consistent guidance will be provided to both parents and teachers regarding when to intervene, how to enforce appropriate behaviors, good behavior, and how to respond consistently. Okay, the big plan is the CRT, competing response training. We will teach Noam to develop a consistent control over tics, identifying early psychological sensation before an outburst. We will teach Noam to recognize the premonitory urge that precedes the tics, before the tics. For example, my stomach feels like it's flipping. I feel warm in my face. And after that, we touch competing movement for the tick. For each tick, we will assign a competing movement, alternative movement. Noah will perform the competing movement for about 3 seconds. Example, for a neck pulling tick, instead of this tick, press the chin against the chest and maintain this position like this. 3 seconds. After that, practice. Noah will practice CRT first at home and later at school. And the reinforcement is the most important thing. Noah will be reinforced after a successful performance with verbal praise and reward from the preference assessment conducted before the program started. Thank you.